Hello, everyone. This is Erin McTighe. I'm with the Environmental Protection Agency here in Region 10 in our Seattle office. I'm very excited to welcome you today to our webinar. Today's webinar is a presentation on opportunities for in-home asthma care in Native communities, with a focus on our work here in the Northwest, our Northwest Initiative, and a tribal pilot project here in Washington State. As many of you are aware, EPA has for years been a committed champion for expanding delivery and sustainability of in-home asthma care. We're also one of the developers of the science that really proves that link between asthma and environmental exposures. And so we're just really excited today, in particular, to be able to share the work that we've been doing here in the Northwest, and specifically in Washington State, to help ensure that Native children who need in-home environmental asthma care can receive it. So I just wanted to thank you for joining us today and being part of this discussion. If you've joined these webinars before, you may be familiar with this process, but just up front, I wanted to quickly share that the question and answer period is actually going to be taking place on a discussion forum on AsthmaCommunityNetwork.org. So you do need to go to that website to participate in the Q&A, and you just can click the link that we're going to send you through the chat function. So to ask questions, you do actually have to be a member of AsthmaCommunityNetwork.org, but it just takes a quick minute to join, and then you can post questions and comments throughout the webinar. It's a pretty simple and quick process. And there's a site administrator who's actually going to be approving the memberships in live time here, so they'll be approved right away and there should not be a delay. And then after the Q&A period is closed, you're still welcome to come back and visit the discussion forum to see what other contributions have been made, and you can still add additional information yourself. So hoping that everyone can join us on that discussion forum after our formal presentations today. So just before we dive into today's presentations and our introductions, I wanted to get a quick sense of who's with us today on the webinar. So we're curious which type of government or organization you represent: a tribal government, federal, state, or local agency, healthcare provider, health plan, or community asthma program. All right, looks like the poll has been closed and we have a good mix of folks on the webinar today. Thanks again to everyone who has joined us. So just to get us started, I'll go over the learning objectives here in just a moment. But again, I just wanted to welcome you to this webinar about in-home asthma care in Native communities with a Northwest focus. Again, this is Erin McTighe with EPA Region 10. I work here in our Tribal Air Quality Program, and I've been with EPA for almost 10 years, most of that time in the Tribal Air Program. My background is in public health, and just really excited to be part of this project. I'm also going to have alongside me here Matt Ekoha-Kayashi and Sean Blackshear, and I'm going to let them just do quick intros for themselves before we get started. Why don't we start with Matt?
Good afternoon, everyone. I'm glad to be here. Like Erin said, my name is Matt. I'm with a consulting group that's local to Seattle called Headwater People Consulting. My personal background is in whole system change. We focus a lot on health in this area, and we have a particular interest in serving Native communities. And a significant amount of our work is in Indian country, both with tribes and with urban Native communities. And thanks for joining us.
Thanks, Matt. Sean?
Good afternoon, everyone. I'm Lieutenant Commander Sean Blackshear in the U.S. Public Health Service. I've been a commissioned officer for 18 years, and asthma, I've been working with that since my daughter's been born. That's something that I deal with every day because she has asthma, so I have plenty of experience with that. Thank you for joining us.
Thanks, Sean. So as you can see on the screen here, we've got a few different learning objectives laid out. We're hoping that through our presentations, you'll be able to learn about what we've learned during our 5-year effort to help both build capacity and explore sustainable funding for asthma and asthma in-home environmental interventions in Native communities, with a focus here in the Northwest. Guidance on a multidisciplinary team was formed with number of really excellent partners from tribes, tribal organizations, federal partners, state and locals, and in particular the importance of really involving tribal voices in our program design and our ongoing work. And in addition, you'll hear from Sean some firsthand experiences as he's a leader of a home visiting program here in Washington State with the Yakama Nation. And you'll also hear about opportunities and barriers to expanding in-home asthma care in Native communities that we've gathered from a number of partners that we work with and from our experience. So hoping that we will be able to achieve that today. We just have one more polling question. So based on the learning objectives I've just shared, we're curious what you're most interested in learning about today. That on-the-ground experience from Sean and his work with the Yakama Nation, how the momentum and partnerships have been built around this tribal work in the Northwest, and then opportunities and barriers to in-home asthma care for Native communities, or something else. All right, looks like our poll is closed. Most folks are interested in learning about opportunities and barriers to Native in-home asthma care, and then kind of equal interest in the first two learning objectives about the on-the-ground experience that Sean is going to be sharing, and then the partnerships and momentum around in-home asthma work for Native communities. Excellent. Thanks, everybody, for participating. So that covers the introduction portion of the webinar, and we're going to jump right into the content next. All right. So just to get started here, I thought I would kind of ground us with the vision that we have for this work, which is that down the line, culturally appropriate, holistic tribal asthma programs are being actively implemented in the Northwest and beyond, and are also sustainably financed across the nation. So, for example, in particular, we've been exploring funding opportunities through health insurance funding streams, both private and public, but in particular Medicaid. And we just really think we're at a moment of opportunity for helping to advance this work for a number of reasons. At EPA, we really feel like we have a responsibility to help with that work. We hear from tribal leaders and staff across our region, which is Alaska, Idaho, Oregon, and Washington, that respiratory diseases like asthma and substandard housing and indoor air pollution are all really high priorities and also just really challenging to address. So historically and now, tribes have been doing really innovative work to try to address these issues despite the challenges. And a piece of that challenge really has been that they've had to piece together different kinds of funding to make this work happen. So through grant opportunities from CDC or Indian Health Service or EPA, as well as contributing direct tribal funds to these kind of programs. So at EPA, we really think it's part of our tribal trust responsibility and our mission to support tribes in addressing these issues, both on the public health and the environmental side of things, and in a sustainable way. So just to start with a couple of slides on some health data, the disparities in asthma prevalence in Native communities are really significant and striking. As you'll see here, there's some data from Washington State that I'm displaying here. And in Washington, 15% of the general adult population has asthma compared to 25% of Native people in the state. And while that's pretty striking alone, from what we understand from a number of partners that we work with, most public health surveillance systems that collect this kind of health data are probably underreporting the Native health data, so the disparity in the prevalence is probably even worse than this. And there's a lot going on this slide, but kind of the key takeaway here is that not only is the prevalence of asthma higher, but the disease itself has a greater burden on Native people. So basically what this slide is showing is that Native patients in Washington State are almost 3 times more likely to be hospitalized for asthma than white patients. And of course, many of you have been familiar with asthma work and asthma burden. This is just the tip of the iceberg when it comes to the burden. It's just showing the hospitalization, so it doesn't take into account clinic visits or other types of exacerbations or impact on daily life. So the positive part of this picture is that there is a solution with a strong evidence base, which I'm guessing many of you are familiar with. So we know that, generally speaking, coordinated, holistic asthma care that addresses both the clinical and the environmental needs of an asthma patient through a home visit in particular can really immediately and measurably improve asthma management. So something that has kind of quick results that can be measured. Some common asthma triggers that we hear about in the Northwest from tribes, and my understanding is from other parts of the country as well, is that wood smoke from wood stoves is really challenging for home heating. Mold and moisture issues are common. Ventilation that's not working or not being used is another challenge, among many other things. And often those types of triggers can be relatively simply addressed with some basic tools, some resident education, and can drastically help improve the quality of life for asthma patients, particularly when done in coordination with clinical care. So kind of to get started describing the initiative here in Region 10, in 2014 we gathered a group of partners to just think about how we could collaboratively work together to address asthma disparities in Native communities in the Northwest. And in particular, we were kind of seizing upon this opportunity to look at the new opportunities that were happening in the public health insurance realm, in particular Medicaid, that now allowed for states to decide whether or not to pay for home visits by non-licensed professionals. So, for example, a community health worker to help do prevention work. And that, in combination, we were also funding, supporting, trying to track the work that Northwest and Alaska tribes were already doing really successfully on indoor air and asthma. So there was certainly already capacity, there's interest, and there was need that we were hearing. So those things combined, that strong evidence base for asthma home visiting, the tribal indoor air work in the region, and then this new policy and potentially funding opportunity through Medicaid have prompted us to kick off a tribal asthma initiative. So we started by putting together a summit in 2014. You'll see some photos on the slide here from the summit. We had about 40 folks participate from a range of different organizations and tribes. And one of the big outcomes of the summit is that together attendees put together what we call the bold goal, really kind of this unifying call to action around this work. So the attendees created this goal of committing to drastically reduce asthma urgent care visits for Native children in the Northwest through both delivering and funding this type of high-quality care. So what you'll see on this slide is I'm going to give a couple of lines of what looks like a very linear process for our work over the past 5 years. So in reality, it was not quite this linear and simple, but for the sake of the presentation today, I'll kind of walk through what the process has been, and then we'll dig into it a little bit more. So we've been pretty busy since the summit. We've been collecting information and convening stakeholders, at the outset, just to get a good foundation of where to start. And then after that, we worked early on to appropriately engage with tribes to really understand what the needs were, what they think the solutions are, and to gather buy-in. And Matt's going to be talking a little bit more about how we approached the tribal engagement. We established a partnership team, which pretty quickly narrowed its focus to Washington State for a few different reasons, not because there wasn't need in the other states, but there's a lot of momentum at the state level with some work around health insurance transformation and the impressive work of the tribes in Washington State, which you'll hear a little bit more about from Matt and Sean. So since then, the EPA has led that team to help identify and support pilot programs. We've been helping with program design, helping tribes figure out how to evaluate and share their learnings. And of course, the ultimate goal here is to really achieve sustainably financed, effective in-home environmental interventions for Native people with asthma. So the interdisciplinary team that I mentioned was established as an outcome of that summit in 2014, and we call it the Northwest Tribal Asthma Project Team. And we just feel really fortunate to have this wise and really engaged group of partners. It includes tribal representatives like the Northwest Portland Area Indian Health Board, the Tribal Healthy Homes Network, the Urban Indian Health Institute, and the Seattle Indian Health Board, among others. And then we also have a number of really committed federal agency partners from EPA, Housing and Urban Development, Indian Health Service, and also the Center for Medicare and Medicaid Services, or CMS. So I'm going to turn it over to Matt now, and he's going to be talking a little bit more about how this team has worked to engage with tribes and tribal leaders and organizations over the past few years.
Thanks, Erin. So critical to moving this work forward has been developing relationships with tribal leaders and organizations that have not been closely engaged with before, and many of them are on the health side. So in addition to those already mentioned, we've connected with tribal health directors of Northwest Tribal Health Systems and Clinics, a tribal leadership group called the Affiliated Tribes of Northwest Indians, and we'll go into a little bit more of that later, or ATNI, the American Indian Health Commission of Washington State, and the Northwest Indian Housing Association. So we found it critical to learn from and develop a shared understanding of the ways this kind of work will benefit these communities and how it's going to do so in a way that affirms the ongoing work of tribal clinics and governments and other leadership organizations. Another thing that we found I want to point out too is that tribes often have different access to system influencers and more flexibility for the internal systems change work that this kind of thing requires. So that kind of partnership has been beneficial as we look to whole system change in a lot of different ways. So ATNI, they're a organization of 57 Northwest tribal governments that they get together and they discuss and put forth policy that they would all share and adhere to. And we had the opportunity to work with their health committee, and we put together a resolution that was passed that really just asked for and got the support of ATNI to support this kind of non-clinical unlicensed professionals in tribal communities, and how can ATNI as a whole community get behind that effort. And we found a lot of traction within and without of Indian country with this resolution, and we're really, really grateful for that opportunity and the relationships that have come out of that. As far as supporting asthma work in tribal communities, this team has deemed it equally critical to simultaneously explore policy opportunities and support on the ground work. As tribes are doing this work, whether or not they have sustainable financing, they've known for a while that it's impactful and it's important, and they've been doing it, and we believe they're going to continue to do it without financing. So it's important to kind of have our hand in both areas. A recent success was securing EPA funding through the Indian Gaming Assistance, or IGAP program in Region 10 for Tulalip tribes to design and conduct a pilot project. Additionally, the team closely engaged with Indian Health Services on their asthma home visiting work on the Yakima Reservation in Washington. You'll hear more about that from Sean, as they have recently begun a program in coordination with their pharmacy and clinic. Headwater People, that's the group I'm with, under our contract with EPA, also connected with the Seattle Indian Health Board, the largest urban Indian organization in the country, to provide technical assistance to look at what an asthma program that involves home visiting could look like for the urban Indian patient population. And finally, we've been tracking and sharing how tribes can participate in the Washington State transformation process and access funding. And we'll go into that too in a minute. So we'll go into detail a little more about each of these activities. And we want to start with Sean Blackshear of the Indian Health Services in Washington State. We're really excited about the work they've been doing there, and we think you'll be impressed as we hear about what they've been doing over the past 4 to 5 years and the results they've seen. Sean?
Hi, thanks, Matt. So I'm an environmental health officer for the Indian Health Service Portland Area Office of Environmental Health. We provide health and safety consultation to federally recognized tribes in the Pacific Northwest. Our focus is on 5 key areas: the built environment, children's environment like Head Starts and daycares, safe water, food inspection, and vector pest management. I'm physically based on the Yakima Indian Reservation in Toppenish, Washington. I've been doing asthma home visits for 5 years now in coordination with the IHS Health Clinic. We started after 2 fortunate happenstances that occurred at the same time. The first being that there was the passage of the Affordable Care Act, which had my management at the time exploring how to integrate our public health practice with primary health care and being able to recover those costs. The second was a pharmacist was consulting in a provider meeting about a patient that was still having severe asthma symptoms after several medication adjustments, and they just couldn't figure out why this wasn't working. And the physician assistant he was consulting with was familiar with my work. I was already doing home visits for a variety of reasons, like assisting with ridding the homes of bed bugs, water testing, or mold remediation. So she told the pharmacist to contact me. And long story short, we eventually came up with a program in 2014 that operated and tracked poorly controlled asthma patients for a year, and we saw some interesting results. So the Yakima Nation Indian Health Service Asthma's pilot, the clinic and pharmacy referred patients to our office. We had 25 home visits. 72% of the patients that participated made environmental or lifestyle modifications. 47% of patients decreased use of asthma rescue medication, and this was determined by a chart review by a public health nurse. Urgent care visits were reduced from 53% to 12%, Emergency room visits decreased from 47% to 18%, and then amazingly, 90% of patients went from reporting asthma as being not well controlled to being self-reporting as well controlled. So those were pretty encouraging numbers. How the program works, patients with moderate to severe asthma who are not obtaining adequate control with prescription therapy are referred to the environmental health officer by a provider or pharmacist. It's open to any member of a federally recognized tribe, so they don't have to be a Yakima Nation native. Home assessment is done by an environmental health officer, and we can include public health nursing where it's applicable. So if we have a complicated patient that, say, has asthma and heart failure or uncontrolled diabetes and asthma, we try to bring in a public health nurse to help educate and be holistic in that regard. Also, if during our inspection the individual or patient reports that they're having problems understanding how to take their medication, we can bring in the public health nurse to do a better job of explaining how and when to use those meds. The findings and the health education are provided to the patient at each visit. So what we see in our home assessment is given to them in writing so they can follow those recommendations. And then those findings are reported to the provider, which they have to sign, and it's put in the electronic health record. So that is there for folks to review, providers, if they end up seeing a different provider instead of the one that sent the recommendation. The home assessment addresses the home environment, work. If someone works with hazardous materials, we try to educate them on not bringing those materials into the home, hobbies, lifestyle, and medication usage. And with that, we're basically asking, are you taking the medicines as prescribed, and do you understand what needs to be taken and when? Next is opportunity to participate in an expanded program after the first inspection, where we'll do 2 additional visits, which consist of continued counseling and medication if needed, lifestyle change counseling, and any environmental modifications. A lot of time home repair is difficult for these certain individuals to afford, or they're unaware of tribal programs that are available to help with making repairs. So we try to highlight that and educate the homeowners about that. Next is incentive materials are provided as interventions. So known interventions for known triggers. So, mattress and box spring covers, encapsulate the pillow with a cover, green cleaning supplies that have low VOCs, and these are known interventions that control common asthma triggers. Another example would be sticky traps for cockroaches. So something that's really inexpensive and easy to put out. And we also do surveillance of the implementation of the environmental recommendations. So when we go back for another visit, we make sure that they are, at least trying some of the recommendations to modify the home. Asthma control diagnosis after the home assessment is also tracked through the clinic. So a few lessons learned. I'd like to mention a couple of things. It is a challenge getting patients to allow you into their homes. People are embarrassed that you might see something that you'll put a judgment on, or they think you're going to demean the way they live. I found that, honestly, just sharing personal experiences work best. Similar to, yes, I hate dusting just as much as you do, or yes, my teenager's room is a challenge to keep food out of it, but it shows that I'm fighting the same battles that they are. And what we're trying to prevent is going to the ER at 2:30 in the morning to get an epinephrine shot. Another observation is choose incentives that not only address the asthma triggers, but that are deemed as valuable. These inspections are time-consuming, and recently work on an NIH grant for childhood asthma. I'm seeing more patients agree to the second home visits because the grant allows us to give grocery gift cards to buy some of the green cleaning supplies and a HEPA vacuum cleaner is given out as an incentive, and also it's extremely useful because a lot of folks can't afford a HEPA vacuum. So with those incentives, I've been invited back more often than when we originally started this in 2014. Also, I would like to mention that keeping a close relationship with your tribal community and your tribal programs, looking at housing, those folks can be instrumental in helping out with trying to relocate folks that are in deplorable conditions when it comes to housing. Also, the environmental management program that's tribal run and the Yakima Nation Facilities Management, they have helped on several occasions addressing deficiencies that I've not been able to get done otherwise. Also, make your face known at the clinical setting. I try to go in and go visit the providers to remind them that I am available, not only for asthma, but for other home visits. And I'd also like to say that our relationship with EPA Region 10 has been instrumental in helping connect and maintain contacts, doing outreach and sharing information like we're doing right now, for instance. So on the next slide, it should say Visit 1. This is the front page of our home assessment. It gives a brief snapshot. This is actually a 16-page report, or assessment tool, excuse me. And it asks us basic questions about the residents' concerns and evaluates what kind of housing that we're inspecting. Next slide should show pest control. This is one of the areas that we address along with mold, moisture, and a couple of, well, actually quite a few other things. Initially, the first question is, has the homeowner seen signs of ants or cockroaches? Are they aware of the infestation if they have one? And if so, are they dealing with it? Also at the bottom, it gives a discussion or suggestions for the assessor who's doing the evaluation if it wasn't me, addresses some of the key messages, and then shows the provider if something we recommended, if a patient's compliant, or if it doesn't apply. In the next slide, it's the flow chart, kind of a visualization of how this works. The healthcare provider assesses the patient, asks them if they'd be interested in a home assessment. The provider refers the patient through EHR, electronic health record, to our office. We schedule that home assessment and then make recommendations on environmental modifications, and then do some health education on the findings. We then track the occupants' changes or behavior to see if the housing situation has improved, and then the provider can review that or monitor that through the medical records, and if need be, can resubmit that patient to us, and we'll go check it out again. Next steps. As you can see, with recruiting, we start young. We are attempting to train health technicians and other tribal programs within the Yakima Nation to do home asthma visits. We're also trying to expand the program to other tribes in the Pacific Northwest. Another step is we're trying to repeat the results of the 2014 study with a more robust evaluation. The IHS clinic, health clinic, our office, and the Northwest Portland Indian Health Board are currently involved in a National Institutes of Health funded childhood asthma study, which we'll talk about a little bit later on in this presentation. So with that, I'm happy to share any tools or insights after this presentation. Feel free to contact me at any time. And I'd like to turn it back over to Matt to talk some more about additional tribal programs. Thank you.
Thanks, Sean. So there's a few other programs that we want to share with you. One of them involves the Tulalip tribes, and their land base is just north of Seattle, about 45 minutes up I-5. And that program, it's funded right now both by the EPA and direct tribal dollars through their community public health program. Tulalip tribes is in the process of building a formal asthma home visiting program, and they're looking to do 10 to 12 home assessments, or make relationships with 10 to 12 families, households, to do home assessments, and they're looking to do about 3 to 4 visits over 6 months. That's going to entail evaluation, education, heavy on the education, and an asthma action plan. In addition, they're going to provide green cleaning kits, and help to support the community in a number of different ways. One of the things that's unique, I think, about this is that they're the public health group at the Tulalip Tribes. They are spearheading this, and so they are separate from the clinic, closely related, but that's one of the things, finding out how do you communicate with the community as a different entity than the one maybe community members may first think of when they think of asthma treatment. Another thing too is that Tulalip, they are really near the water, and they have significant challenges with mold and moisture that's widespread throughout many of the structures. So the need is great there, and we're really excited about the work that they're doing. Some of the outcomes they're going for is they're looking to increase the capacity to manage asthma. They're looking to improve clinical outcomes, and they also have a strong focus on how do they measure the quality of life changes that happen from this kind of program. Another effort that we've been involved with is with the Seattle Indian Health Board. Now, that's not connected to a particular tribe. It's an urban Indian organization serving not exclusively, but specifically Native people and American Indian and Alaska Native populations. They are one of the largest, or the largest, urban program doing clinical care. They serve 6,000 people annually, 4,000 of which are Alaska Native and American Indian. They are in the early stages, and we've been supporting them for a couple years to develop a design that works for their organization and their population. And actually, they've got a really cool head start. In 2014, they were part of a pilot program that did home visiting. They saw, in 8 months, they saw 379 American Indian and Alaska Native families. From that, they had 152 appointments, and of that 152, they did 26 visits, home visits. So that gives you an idea of the challenge between, getting people involved in the program and then actually getting into the home. And currently, they are looking to how to continue a program like that with sustainable funding, and we've been supporting their efforts over the past couple of years. So you can see a graphic of their vision of how this works. One of the programs that we've identified that could possibly work for them, and this is something that came out of in our 2014 summit, is the Washington Medicaid Transformation program that's going on in Washington right now. So that's for those of you who aren't aware, I'll just briefly give you a real high view of that program. It's a 5-year demonstration project. It's a contract between Centers for Medicare and Medicaid Services with the state of Washington. They negotiated a few years ago this contract. The triple aim, the goal of this, is to reduce avoidable use of intensive settings and services, emergency department care, secondly, to improve population health, and 3, to accelerate the transition to value-based payment. You can see the map on your slide. That's the different accountable communities of health that are participating. So the state has been divided up into these different ACHs that are participating as community-led efforts to this kind of work. And the most populous one is in our county, which is in Seattle, the King County ACH. And with Seattle Indian Health Board, that we've been able to partner with them and provide them some support to first start with their design of the asthma program that they would like to continue to run out of the Seattle Indian Health Board, and to get that design in front of the architects of the King County ACH. And we were able to join in as a design participant with Seattle Indian Health Board to get the interests and the specific needs and capacities of Native people in this population, or in King County, and how do they keep those things in mind as they're designing the different changes in the transformation waiver process. So this has been a really interesting, a really broad-reaching, and a very emergent process that we've been a part of with them, that there is no clear roadmap, that the state negotiated a lot of things and left it up to these ACHs to figure out how to get there. And so our ACH, like all of them, are still figuring that out. We've been really pleased that we've been able to see that the American Indian and Native Alaskan interests have been kept at the forefront, but also figuring out what that means practically is always a mix of challenge and confusion. But we've been really, really pleased that we've been able to be a part of that process. Tribes in the area, there's 2 tribes that are within King County and therefore within the ACH, and we have made a lot of efforts into connecting them with the program as well. Looking forward, there's also additional exciting momentum expecting from the work that's been funded by the NIH program. That's what Sean mentioned really briefly in his program. The Northwest Portland Area Indian Health Board was awarded a grant to support pilots at 4 tribes in the Northwest, and they're still ironing out the details of all those tribes, but we know that Yakima will be one of those. This project aims to measure the impacts of combined clinical and asthma home visiting program. There's really strong alignment in this program with the work that we've been involved with through Yakima, with Tulalip, Seattle Indian Health Board, and around the region. So there's that alignment's strong. But they are additionally attached to document protocols, practices, learnings, and develop materials for other tribes. So they are in the process of negotiating and doing some research to figure out those other tribes in addition to Yakima. Some of the things we've learned, and we've recently been having some just conversations with relationships we have around the state and the region, and we wanted to share with you some of the key points of successful what an in-home program would look like. So these are like the 2 things on these slides: data infrastructure and policy challenges to figure out how do you connect, having the capacity to connect within and without your current health system. So for like in ACH, the need to be able to track patients in a way that's going to support this kind of program is very important, as well as how do you share that information with other providers where Native people may be getting their care in other areas too. So having the infrastructure that can support that kind of work. And along with that, how do you have communication with clinics so your doctor can communicate with people out in the field? How do you document those things and have it streamlined in the way that can support this work in conjunction with the other work that these clinics may be doing? Those challenges are really important to think through. Policies, in addition, the current tribal health reimbursement is really based on fee-for-service models, and the financial incentives for clinics to adopt system-based care, they're sometimes unclear. So doing the kind of evaluation that looks at the value and cost of multiple variables, from clinic costs all the way to quality of life, that's important too, because the math doesn't always work out as cleanly as we feel that would be helpful. So thinking through those questions are really important as well. Moving on, it's also some things we've learned, finding the key partners. It's tribal housing when you're talking about like tribally based programs. That's so important that many of these challenges can't be addressed without having a strong partnership with tribal housing. So making sure that those people are at the table, involved, share the vision is important. And also like the capacity to have partners that can deliver education in non-clinical settings. Very strongly connected to that second bullet point of culture componency. So getting to any home is really challenging. I'm sure many people on this call know and understand. In many ways, for American Indian and Alaska Native, those communities, they may have additional barriers for letting government-type people get into their homes. And so understanding what they may feel may be at risk, how to address those concerns with people who are very culturally close, if not from that community. We continually hear that that's really important. And these, community health workers, they have to have a whole range of skills, from culture competency to different set of skills to do this kind of work. So we wanted to highlight those kinds of learnings. I'm going to toss it back to Erin.
All right. Thanks, Matt, and thanks, Sean. So I'm going to close us with talking about some plans for moving forward and some additional lessons learned. So where are we going next? We've been busy over the past 5 years, and we still have a lot planned and a lot of work to do. But broadly speaking, what we're hoping to do is to continue to support the work on the ground, so some of the programs we've already heard about, and hopefully new tribal projects as well, but also simultaneously leveraging that higher scale, bigger systems change work. to support sustainable financing and capacity building over the long term. So at EPA, we're hoping to continue to lead and support that team of partners that I mentioned up front, the Northwest Tribal Asthma Project team, because all of those partners are really critical in helping to move this work forward from different angles. We also want to just try to find the right times and venues to engage with the state of Washington or other key decision makers on Medicaid transformation work. So as Matt described, for example, by making sure those decision makers are aware of the existing tribal programs, what tribal needs are, what the successes have been. And as an agency, our role is really to educate and elevate about those tribal needs and the evidence-based solution to those needs, which we're learning more and more about. Our team is going to continue to work to report back to the tribal groups that we've engaged, the ones that Matt mentioned, to continue that connection and collaboration. And we imagine that we will also be engaging some new tribal entities as needed as we continue to roll this work out. And another key part of that work is kind of doing what we're doing today, and that's really just tracking the work, the progress, where more progress needs to happen, and packaging that and sharing it with those who might be interested in learning it or decision makers in different areas. We want to make sure that we can share the keys to success that tribes have shared with us so that any policy or program or funding decisions that are made really take tribal considerations into account. And then kind of digging back into the support of the work on the ground, we are planning to continue and are continuing to provide technical assistance to the work that Tulalip Tribes is doing, as well as Yakima, the work that Sean mentioned, and other programs that we imagine will be coming on board. For example, the sites through the National Institutes of Health grant that Matt and Sean mentioned. We've been able to provide guidance on how to design a pilot project, share models and considerations and different learnings from other parts of the country, not necessarily other tribal programs, but other programs that have followed similar models and encountered similar barriers and have lessons to share. So that's been exciting. And we've been able to provide guidance on how to best plan to evaluate a program so that tribes are well positioned to receive funding in the future should that come along in one way or another. We're hoping to continue to work with the Northwest Portland Area Indian Health Board and tribes generally to track the learnings and create and share tools that could be used by other tribes and communities as part of the NIH grant. They're doing a lot of work to put together training modules and tools, and we're going to be working closely with them on that. And we also hope to continue to do that facilitation, connecting decision makers to the information that we're learning, and also to make sure tribal leadership knows when they have an opportunity to connect with decision makers around policy and program funding. So just to close here, I have a couple of slides about the overall learnings of our project teamwork that we're hoping might be helpful for others who might be considering embarking on this work in one form or another. So looking back at our somewhat nebulous process, we've learned it's really critical to understand, from the very beginning, what Medicaid looks like in each state. Structures are different from state to state. Washington is different than Idaho, is different than Oregon. There are different opportunities under each one currently for funding different types of asthma work. And of course, the political landscape is going to be different in every state as well, so opportunities will be different. It's also really critical for us to understand, what can be paid for right now, and also what tribes or other communities are already doing and having success with when it comes to asthma, home visiting, or just more holistic types of asthma and chronic disease programs. Pulling together the right people from the very beginning was so useful to us in identifying a focus area to help get momentum going right away. So I mentioned the focus on Washington State, specific focus on tribes. That really helped to kind of narrow focus and keep people engaged and really feel like they had a common goal. And then a demonstration project. We knew from the beginning that at least one, if not more, would be really necessary, both for developing infrastructure on the ground, learning what works from tribe to tribe. We know the solution is not going to be the same everywhere, but there may be some commonalities. And then also to gather the data on the health and the economic outcomes of these kinds of programs, because state Medicaid programs and other insurers and payers are going to really need to understand, what the return on investment looks like, what the value of these programs are. So in terms of, the overall interdisciplinary work and the immediate team, and then broader group of partnerships, what made that successful we think was having really a committed group of partners from a number of different sectors. So you heard us talk about partners from housing, health, environment, health insurance, so a range of expertise and a range of roles, but with a common goal. And another key helpful piece was that we did have some good foundational partnerships to build on with a number of partners like those from HUD and some of the tribal entities and Indian Health Service. We've been working together since before 2014 on a different number of aspects of tribal indoor air and housing related work. So we were able to not just start at square one, but be able to build on that and bring in new partners. And then, as Matt described in detail, just really active tribal participation and input throughout the process was really critical to make sure that all of the work and time we were putting in really was making sure we were heading towards the right direction, filling the needs that we were hearing from tribes. And again, we had a really clear vision for what we hope to do, improving health and housing conditions for a really specific population. We all could agree upon the goal. And perhaps most important was just this culture of moving forward, even though we didn't have all the information or answers. And I would say that is still true. We're figuring it out as we go, learning from other folks across the country, some of you who are probably on the line. But we're hoping to share what we learned too, so we can help contribute to that. So that brings us to the end of our presentation today. We'd like to close with our contact information. And just want to give a big thank you to everyone who joined to listen to our story today. You are welcome to reach out to any of us individually with questions that you have. We would love to hear your ideas, your experiences, any questions that you might have. So you can see our contact information there. But we're also hoping that you'll be able to join us in the online discussion that we mentioned, which is going to be happening right away here on AsthmaCommunityNetwork.org. So we're hoping you can all navigate to this website, to the discussion forum, and I believe we're going to drop in a link to that as well into the chat box here. And just a reminder that you do need to join Asthma Community Network as a member, which is free and easy to do and will be pretty quickly approved, so you can join in the discussion right away. And then after the Q&A period is closed, you're also welcome to come back and look at the discussion forum to see what's been added over time, because we imagine the conversation will be continuing. So thank you everyone again, and thanks to Matt and Sean for participating today, and we look forward to talking with you more.